So hello, everybody. My name is Susanna Neufeld, and I live in Berkeley, California, and I work in Oakland, California. I'm a licensed marriage and family therapist. I'm also a certified eating disorder specialist and supervisor through IADEP, and I am a certified advanced EFFT therapist and will hopefully be a supervisor in a few months. I have a huge passion for EFFT and this work, so I'm thrilled to be here. Oh, my pronouns are she and her. And I'll tell you a little bit about myself. I'm a therapist by all of those qualifications, and I've been treating eating disorders, several settings from residential to IOP, but mostly for the last 10 years, it's been mostly in, maybe actually since about 2009, it's been mostly in private practice, all through the lifespan, eating disorders from teenagers through adults, lots of family therapy, lots of individual therapy. And before we jump into this topic of integrating FBT and EFFT that I'm so excited about, I just want to start by saying that the reason that we're talking about all of this, you know, even though I'm excited about the topic, it's also because eating disorders are so painful, right? They're really, really painful, challenging illnesses to have, to be the parent or caregiver of someone who has, and certainly for everyone who's here, they're really painful and challenging illnesses to treat. It's very humbling to treat people with eating disorders, to care about and for them. The work, even if we have all the training in the world, it can take a long time. It can be complex. It cannot work. Eating disorders can be chronic and life-threatening. They're so miserable, and we're so in need of new and more effective treatments. We're in need of more ways to fill our souls to stay with this work. And you know, this is it, because it's so heartbreaking, and it sort of requires us to have to also go against our whole culture, everything our culture throws at us in terms of diet and body, emotion, that, you know, I think that it's important to hold on to hope and compassion. And so I'm grateful to all of you for being here. If you're showing up here, I'm guessing it's because you're wanting to be in this space of creating hope and compassion, space for healing, connection, for the families that we see in the face of this illness. So I'm grateful to be together. I just saw someone asked if we can get the slides. I will figure out how to get that afterwards to you. And one quick thing about the chat box, I am going to leave time, if we have time somewhere in the middle, to look at the chat box and answer questions. And then I will leave about 10 minutes at the end, hopefully, to also answer questions then. But I'm noticing that I keep seeing it when something pops into the chat box. So if you can hold your questions for when I ask, that would be great. And hopefully some of the questions will get answered as well. So I'll share a little bit about my own journey in treating eating disorders and why I love using FBT and EFFT, because I think that my own experience in some ways tracks some of the changes and developments in our field. So I got my degree in counseling psychology and actually in expressive arts therapy in the early aughts. I had come from a background of doing theater, and I really fell in love with this idea of using the arts to express and process emotions. The work in that phase of my career felt super magical. I really, really loved it. My first job was working with adults with substance use disorders and eating disorders. And I used a lot of the expressive arts to do that. And one of the approaches in that expressive arts world that I was introduced to and used a lot is narrative therapy, which you can see some, if you have experience with it, parallels with both FBT and EFFT. And, you know, in narrative therapy, there's work on kind of helping people externalize or personify their problem. So with the arts, there was a lot of beautiful work with that. And then I started doing that work with adolescents at an eating disorder treatment center. And in that job, I had to do family therapy sessions every week. And I found that to be the hardest part of my job. And, as you know, inherent to the model of teens in a residential treatment center is that they're separated from their parents. Their parents aren't there. The idea is that they're going to do better if we can kind of get them out of the home for a while and give them intensive treatment. This was about 2006, 2007. And the general feeling I had in the field, some of the shift was happening, but it hadn't yet reached the place that I was at. There was a lot of kind of gossiping and negativity about the parents amongst treatment providers, like, wow, this problem is really here because of these difficult parents. And I felt that in the family therapy sessions I had, like, wow, the parents were a little bit to blame for this, and why aren't the parents changing? And I'd spend a lot of time feeling frustrated with the parents. In fact, I thought maybe I'll only work with adults, because with teens, I'd have to work with the parents all the time. Somewhere in that period, though, I was introduced to the idea of FBT, which at first was being called the Maudsley method, sometimes still calls that, of involving parents and putting them in charge of helping their kids heal from an eating disorder. And I will be honest with you, when I first heard it and somebody asked my opinion, I said, it sounds really abusive. I thought it sounded horrible. I thought it sounded like it would traumatize both parent and kid. I did not think it would work. But I then kept hearing about it and hearing about it. And I'm a big nerd for learning. I love trainings. And so I decided to go and do the training. And I actually found the training super compelling. I loved the idea that the person with the eating disorder wouldn't be alone in their struggle, and they'd have the support of the family. So I just decided to try it with one family. And then just as I started it with one family, I had a colleague who was an FBT therapist that had to go on medical leave, and she transferred some of her cases to me and was generous enough to mentor me through those cases. And wow, that work was so amazing. I really was able to see that instead of the kids getting traumatized, they felt super supported. And honestly, the work was way easier for me. I didn't feel like I was the person who these kids had to lean on, and I had to hold all of it. I was able to see them connect to their parents, get closer to their parents, get better faster. The family relationships were better. I loved the idea that they could sort of see that their parents were bigger and stronger than the eating disorders. It's such a relief for the kids. So I got hooked. And for a lot of years, this became the main way that I practiced work, was using FBT. And that's been about at least half of my practice ever since then. There are still many cases with FBT that felt really hard or got stuck. Even the research on FBT, it's the most evidence-based approach for young people, adolescents with eating disorder, with anorexia, and still lots of evidence for using it for ARFID, binge eating disorder. We'll talk about that, bulimia. But, even with the, most typically case that was done in the study, it didn't go well all the time. It really works 50 to 70% of the time, depending on what study you're looking at. That leaves a lot of people who it wasn't enough for. And I noticed that those cases, the ones that got stuck, actually felt the most draining for me in my practice. And I'd feel a lot of frustration continuing with the parents for not following the protocol. Maybe I'd feel frustrated with myself for why I couldn't get through to them. So that's sort of my story with all of it. And then I learned about EFFT. And I think it's interesting, if any of you have ever heard Adele LaFrance talk about the development of EFFT, you'll know that some of what led her through to develop this approach is very similar to what my own experience was. So I heard her present about 3 years ago at a conference, and I thought, oh my gosh, this woman is speaking my story and my language, and she cares about these, clients as much as I do. And she's got some tools that I actually don't have and that I need. And so I immediately dove into looking for supervision in EFFT and using it with my clients. And it's been incorporating the EFFT and FBT together has been a total game changer in my practice. I think this has been my favorite 3 years of work as a therapist. I want to say I'll talk today a little bit about each approach and how I like to combine them, but I also want to say, I think of any approach that you're gonna use with EFFT. I'm assuming most people are here because they're EFFTers. I think FBT in some ways is such an easy fit because it's FBT is where EFFT sort of started. I know it comes from other things as well, but because it had that hand holding right at the beginning and was developed as an adjunct for it, I think you'll see that they fit together extra beautifully. And there's a lot of ease in combining these approaches. And I also want to make a disclaimer that I certainly don't speak for FBT as a modality. I'm not certified in it. When I did my training, the certification didn't exist. And so I never went through that. And that I believe there's a research group that Adele is part of that's working on a protocol to combine the two. But most of what I'll be sharing today is what came out of trial and error and wonderful supervision with Natasha that I've figured out kind of what has worked in a private practice setting in the United States. So that's my journey and why I love using them. So let's start by talking a little bit about what FBT is. These letters we use, sometimes people say it's family-based therapy, but it actually stands for family-based treatment. And it's also often called the Maudsley method because it came out of the Maudsley Hospital in England, in the UK. It is the most evidence-based treatment for young people with anorexia nervosa. That's people under 18. However, there's lots of emerging research of using it. There is research that it can be really helpful with transition age youth. So that 18 to 25, 26, and I've certainly used it a lot with some modifications, and EFFT is really great with that age group. And then there's actually lots of research now using it with adults as well. And while the greatest evidence is for anorexia nervosa, it can be used OSFED, if people don't know, is kind of other specified feeding and eating disorders, sort of other versions of eating disorders that don't meet the very strict criteria in the DSM for anorexia or bulimia or binge eating disorder, ARFID, but people who have a maybe an emerging eating disorder or a more complex picture can actually be, and often is, more serious or as serious as these labeled eating disorders, and FBT can be wonderful for that. And then with modifications for these other eating disorders as well, there's a whole protocol to use it for ARFID, which is not my specialty area, but I've seen it be really, really helpful with that as well. FBT draws primarily from family therapy approaches like structural and strategic therapy. It supports parents to take an active role in restoring weight in anorexia. If necessary, weight needs to be restored. And then in the case of other eating disorders, reducing the symptoms of the eating disorder, restriction, binging, purging, etc., exercise. And it also focuses on supporting healthy adolescent development. Okay. So let's talk a little bit about the stance of FBT. So the first stance of FBT is that of caregiver empowerment. And again, if you're an EFFTer and you're here, you can see that natural connection there. Caregiver empowerment is at the heart of both of these approaches. The caregiver is made integral to the treatment versus what we used to call the parentectomy, that kind of idea of parents shouldn't be part of it. They shouldn't be the food police. They shouldn't, the therapist shouldn't talk to the parents. Maybe the kid even has to just go be apart from the parent for a while. Instead, we're saying the parent is actually the greatest tool or the caregiver that the person with the eating disorder has for healing. It respects their expertise about their own child and their kind of cultural norms in their family as well, which, I think I'm going to talk about this later, but it's one of the reasons I think that it's a good approach for being respectful of people from all kinds of backgrounds. And it does charge the parents with the tasks, the behavioral tasks of the refeeding and normalizing of eating process. We believe the caregiver bond is the most powerful tool for healing. So there's love embedded in this FBT approach. We work hard in FBT to interrupt patterns of blame, shame, guilt, and criticism. through an agnostic view of the cause. So an agnostic view of the cause is kind of to not spend really much time or any time looking at what happened to cause the eating disorder, or to say it's the fault of a dysfunctional family, but rather to focus on how to treat the illness now that it's here. It's kind of like that EFFT saying of, it's not what happened, it's what happens next. And then the other big piece that's used to interrupt more the blame and shame that might happen to the person with the eating disorder is the externalizing of the eating disorder, which, made me excited because of my background using the narrative approach. So this idea of, instead of saying, to the person with the eating disorder, you're doing this, you have these distorted thoughts, instead to sort of talk about your eating disorder, or your starvation, or, whatever the person wants to name it, Ed, Anna, whatever they decide to call it, that's a part of them that's not necessarily bad and might be there because it has needs that need to get met, but that the person themselves is not to blame for having this illness. And that can be done all kinds of ways, creatively or not. And then a really important piece of the FBT stance is that there's a huge focus on weight restoration and symptom interruption. So this idea, which I think is very, very important, of getting full nutrition in and making sure that somebody isn't restricting. And that's, by the way, really important with binge eating as well. But really making sure that if the person gets that food in and they get restored to the weight they need to be at, they're eating all these foods, that sometimes that's the most important thing for healthy psychological functioning. It's not necessarily about going into deeper issues, but it's sometimes about just letting the brain be fully nourished. And, you can look into the research from the Minnesota starvation experiment to understand a little bit more about that. But that is a really big focus in FBT, and that is addressed in every single session. And then also on healthy adolescent development. How do we help the person move on from sometimes where things get interrupted in development with the eating disorder? So the format of FBT, this is sort of the general format. And I think in private practice, people do it all kinds of ways, and in different treatment settings, people will use a FBT informed approach and do some of this, but generally they're kind of hour-long or 45-minute, 50-minute sessions. The first 10 to 15 minutes are done with the adolescent or the person with the eating disorder alone. And then the rest of the session is done with the family. In a transition age youth, the session is made longer so that the person with the eating disorder gets more time. There's research to show that the conjoint FBT and separated FBT are actually not that different. So conjoint would be the rest of the session was the whole family together with the person with the eating disorder, and then separated would be more of the time is done with just the parents or caregivers. And that you can see is sometimes works well with EFFT. In the protocol for FBT, it's 10 to 20 sessions over the course of 6 to 12 months. I have to admit, I have never seen it go 10 sessions in my practice. I don't know that I've seen it go 20 sessions. It's usually longer, at least, a year of good solid sessions, sometimes more. And that's a piece that I always want to say, is that I think, it's okay to understand that, especially in private practice, we can see really complex cases where there's all kinds of things that are going on, and it's not always as simple as just addressing the eating disorder and then everything is better. So a longer course of treatment can be part of the picture, but I wanted you to know what the standard is. And generally, by the way, in FBT, there's not used a dietitian, there's not used individual therapy for the person. However, a lot of the time those things are added in. The parents might need to see a dietitian to get some help understanding what they're figuring out what they want to do about food. And then the person with the eating disorder may want individual therapy to work on co-occurring conditions like anxiety, depression, self-harm, things like that. The focus in the sessions is on weight restoration and symptom interruption if weight restoration isn't part of the picture. And in every session, the progress is carefully evaluated through weight charting and symptom monitoring. Throughout the week, the person tracks symptoms if there's binging and purging and things like that are going on. But there really is, especially in phase 1, phase 2, which we'll talk about, sort of this idea that in every session, we're really trying to bring the focus back to the eating disorder and resolving those symptoms. FBT is done in 3 phases, and I love to talk about the 3 phases of FBT because so many people think that there is only 1 phase of FBT. So I want to make sure that you have the information that there are 3. So phase 1 is the one that everybody knows about, and that's where the parents and caregivers are charged with weight restoration and symptom interruption. So in the first session, we explore how the eating disorder affects each member of the family versus focusing on how each member caused the eating disorder. We assume that family dysfunction might be the result of the eating disorder, not the cause. We do that separation of the eating disorder in the adolescent, and we mobilize parents by increasing their anxiety. Actually, we try to get them anxious to an optimal point by emphasizing the seriousness, life-threatening nature of the illness, and talking about how difficult recovery in eating disorders can be. And then we give them the charge. We give them the task of weight restoration and symptom cessations. In session 2 is actually one of my favorite parts of FBT. It's a family meal done with the therapist. And during this, you have a meal in the therapy room, or now a lot of the time over Zoom, which actually I think is so great because you can see people in their own kitchen. And the goals there are first to assess the family's strengths and weaknesses or skill deficits and figure out what we need to work on. And second, to give the parents a chance with your support or our support as the therapist to help the kid beat the eating disorder by getting them to eat a meal that they need to restore weight. The parents in phase 1 are helped and encouraged to work together as a team. They're encouraged to problem solve, to choose strategies, and this is really key, that are based on their own expertise with their child. So it's not so much about coming in and saying, here's how you do it, this is the FBT way, but it's really using sort of different methods of questioning to help the parents figure out what has worked with their own child in the past, and what they know based on their own wisdom about what might help their child move through some of this. There is an effort made to reduce harsh, critical parent behavior, including threats, nagging, guilt, or focusing on too many problems. Like, it's not enough to work on the eating disorder. We also want you to, clean your room. We really try to focus in on that one piece. And this piece of reducing that harsher critical parent behavior is a piece to bookmark in your mind of where I think EFFT can be really helpful. So the rest of phase 1 is helping parents stay focused on the task of refeeding, supporting them with problem solving and skill building, and continuing to kind of modify any criticism that comes up and to separate the eating disorder from the person. Especially there's a lot of work on kind of what does the eating disorder want versus what does the kid themselves want. Okay, phase 2 involves carefully returning over the responsibility of food to the adolescent. So this is the phase that people sometimes don't know about. Like, they think that FBT is just phase 1, the parents make you gain weight and then you're done. And then the whole thing was very difficult and painful and everybody is burnt out. But actually there's this lovely phase where we're working on helping the young person learn how to take over the responsibility for food themselves. And we're focusing a lot more on developmental issues during that phase. Phase 3 is the best. That's when the kid is, or the young person is really able to manage their food. They're at their weight restored. Their symptoms are not in the picture anymore with food. They are likely still struggling with body image because that is how this goes. But we're focused on how to help the family move forward. We're exploring issues of healthy communication, problem solving, hierarchy within the family, helping the co-parenting relationship, because that can sometimes be difficult through phase 1 and phase 2, and focusing on relapse prevention. So a couple of skills that are used in FBT. So first, we work really hard to help the caregivers work together as a team. We work on alignment and communication and problem solving with the parents. EFFT has some great tools to help with that too. We teach the parents the 3 C's to be calm, compassionate, and confident in their approach. I should make it 4. I think consistent is supposed to be on there too. Calm, compassionate, confident, consistent, all of those things. We work on feeding to restore health. And again, that's where we want to really let the parents figure out the approach that works for them and to honor every family's way of eating. But some families don't have a good sense of where to go and want some guidance. And some of the approaches that we take by this are using, one of them is the magic plate. So a magic plate is where at every meal and snack, the caregiver presents a plate of food to the kid that's enough food for them to restore their weight and has a nice variety of different foods on it. And the kid isn't asked, what do you want? There isn't a lot of negotiating about the food. The parent is asked to think about what the kid might have liked eating before the eating disorder was in the picture, if they can remember back to that. So the kid doesn't have any responsibility for preparing or organizing or plating their food. It's just magically presented to them, and then the parent is focused on supporting them with it. I love the plate by plate approach, and later in the presentation, I'll have a link to the book, but for parents who really want guidance on what a plate should look like, there's a wonderful approach that I like much more than exchanges or calories or things like that. But there are some families that really want to do calorie counting to make sure they're giving enough food. And again, in FBT, we're really neutral. We want to do whatever is going to work best for the family. And regular eating, which is 3 meals and 3 snacks. And I really want to make a point of saying that we do this with anorexia, restrictive anorexia, and we also do this for binge eating disorder. One of my favorite points to make is that binge eating disorder is most usually also a restrictive eating disorder. So people might have the big problem that's in everybody's face is that they're binging, but that throughout the day they might be restricting as well. And so having these steady, regular eating, all the food groups, nice full plates actually helps, is the most important thing that the caregivers can do to help reduce the likelihood of binge eating later in the day. At meals, parents are taught to approach it with firmness, clear prompts like, take a bite, rather than a long lecture about why the food is important, to really just stick with short, clear prompts. Soothing skills, distraction. There's exposure, like exposure and response prevention kind of techniques, chaining, especially with ARFID, from safer foods to feared foods, and also exposure to binge foods, which might seem counterproductive. We might think, oh, they binged on this food, we should keep it away. But actually, we want to incorporate that so that they can get used to eating it with other people around in a non-binge context. FBT skills involve support after meals, especially to interrupt binging and purging. Interrupting over-exercise is a big part of it. And then parents are encouraged to learn effective limit setting, understanding how to give natural consequences that make sense, like you can't go to school until you eat your breakfast, versus, if you don't eat your breakfast, then you don't get a present for your birthday or something like that. And then positive reinforcement, so rewards, which sometimes don't work with people with real restrictive anorexia, but that can sometimes be a helpful tool. And then teaching parents about the importance of consistency versus what happens when there's an extinction burst, right? Where you say, you have to eat this meal over and over and over again, and then one time you let them restrict, then it might make the whole thing kind of get much bigger. Okay, I want to just take a second to share myths about FBT, because these are things that I hear all the time when people hear me say that I do FBT. So one myth about FBT is that it involves force feeding. That was actually the term I think I used when I first heard of it, of like, this is force feeding, and it's not, it's supported feeding, supported eating. That it's only behavioral in focus. I think that, again, that comes from sometimes places that do an FBT informed approach, or, a person who's not doing the entire approach and isn't really giving the family support with those family dynamics, but just says all of FBT is parents are in charge of food. And I think that that's given it the reputation of only caring about the behavior and not caring about these the family and the people in the family. That it's an individual therapy approach. So I've just heard before people say, oh, I got FBT, and then I find out that it was only the adolescent or young person had therapy, and maybe the therapist was sending emails to the parents telling the parents to feed them, but really it's not an individual therapy. It's lovely to have that and do FBT informed individual therapy, but people should know that FBT really does involve the whole family, and really the parents or caregivers are the focus. It's a myth that it works for everyone. Again, it only works 50 to 70% of the time, and that's with people in a research study. So I think I love FBT. It's what I do. And I don't want people to feel like if it didn't work for them, something was wrong with them, because it doesn't work for everyone. It's one approach, and we need more. That it only works for younger kids and adolescents. I've had people say before, oh, you can only do that with someone under 12 years old or something like that. But actually, it's even been shown to be helpful for those, transition aged youth and adults. A big one is that it only works for easy kids or less sick kids. And I think that couldn't be farther from the truth. I think it's really hard to predict who it's going to work for, actually, but I think it is true that it's more likely to be helpful in the first few year or 2 years of an illness than later on, although not necessarily, but it can work with, parents will sometimes say, my kid's so stubborn, I don't think this would ever work with them. But those are sometimes the kids who are the most scared and who this is the most healing for. It requires a 2-parent household. Also not true. I've done this with single parent households, with divorced households, with 4 parents, 6 parents, grandparents, foster parents. There's anyone who if there's any caring figure in that person's life, they can do some of this. So it doesn't require a specific kind of household to be there. The only thing is that all the caregivers have to be willing to get on the same page about the treatment. It really is hard if they're, one of the caregivers doesn't agree with the approach. So you do have to get everyone on the same page, but they don't have to all live together or like each other. Another myth is that it can't be done with a parent with a mental health issue. Also not true. So many parents are struggling, and they can still really show up for their kids in this way. They just might need more support themselves to cope with it. And another one, the last one I put here, is that it destroys the parent-child relationship. And I get where this myth comes from, because I think especially if we do that sort of only phase 1 model, it can be very painful for the relationship. So I think that the whole model actually, in my experience, creates this amazing bond between the parent and the kid that then emanates out to other things that happen over the years, where the kid really feels, even as an adult, like their parent has their back, and like they know how their parent can help them through any challenges that come up. So that's a good segue into what I love about FBT. And so a lot of it I've said already, so I'll go through this a little bit quickly, but it helps get nutrition on board much more quickly, which, especially as an individual therapist, is very helpful to have that nutrition on board, brain working really well. Then you can get into all the fun stuff in individual therapy. That it can be very culturally flexible, because it follows the family's food preferences, food choices, wisdom, culture. It relieves the burden of the person with the eating disorder. It's okay if they never talk at all in therapy, or they can be really mad and yell at everyone. And really, we try to hold that. This is that narrative piece of the eating disorder can get mad at the parent or caregiver, get mad at the team, versus the eating disorder getting mad at the person with the eating disorder. So I always think it's good when that anger is turned outward rather than inward. So I think this approach just makes it a little bit easier on the person than asking, a teenager who's starving or a young person to kind of on their own have to stand up to the eating disorder. And then the biggest piece is that piece I said before, that it's this beautiful family bonding work. I've actually always viewed it as an attachment kind of therapy, under the radar. That's what I think, that it can give a kid another intense dose of that early childhood parenting, where the parents are really with them all the time, and it just sets them up really well for the future. So this is that piece. I think it's from Janet Treasure that's in all these EFFT slides about if it's working, keep doing it. And with FBT, I think it's a lovely approach. And when it works on its own, you keep doing it. But I want to share with you where I often got stuck in the approach. Sometimes the kids would say that it was so focused on food and weight that it didn't help with their emotions. Parents and caregivers would often feel super frustrated that I was asking them to help figure out what they wanted to do, and there was no manual for do it this way and it will work. The parents and caregivers would get really afraid of their young person's big feelings and feel like they didn't have any skills to handle the big feelings. And that's not super part of the model. And so I'd see a lot of burnout in phase 2 and parents kind of giving up monitoring and helping with meals, letting things backslide because they didn't want to have big fights anymore. They were just so tired of it. I noticed I was getting frustrated with parents for not carrying out tasks that I asked them to do. And there was not a way to work in the model with caregiver emotion blocks. And that is our segue to EFFT. So I think everyone here likely knows a lot about EFFT, but I'll share this, quote from the website, the EFFT website. It's rooted in a deep and unwavering belief in the healing power of families. The essence of EFFT is to afford caregivers a significant role in their loved ones' mental health and well-being. And the therapist's role would then be to empower and support the caregivers. So you can see how well already this parallels the FBT stance. Here's the EFFT stance. More similarity, right? Caregiver empowerment and involvement. But there's also this focus on emotion processing, both the patient, the kid, the adolescent, the young person, and their caregivers, and by the way, the clinicians as well. There's a focus on skill development, foundation of no blame, collaboration and transparency with the client, and the 1 degree effect, right? The idea that this is part's a little different than FBT, whereas FBT says we really got to go for 100% on the food and all of those things. In FBT, in EFFT, we focus on even just shifting things 1 degree is progress. It's one of the reasons I think EFFT is really good with those more severe and enduring eating disorder cases. So here are the nuts and bolts of EFFT, supporting the parents and caregivers to become agents of healing by increasing their role in behavioral support. So again, that's that symptom interruption, the emotional support. And there's therapeutic apologies, which are not set up as a way to blame the parent, but rather to relieve the burden on the child. And this is because, as we know, many of our young people with depression or eating disorders will blame themselves, like, what's wrong with me that I have this problem? So many of my kids tell me, they're yelling at their parents all the time. And then when I talk to them, well, they're like, I feel so bad that I stress my parents out so much, or that I act this way. So the therapeutic apology is to help relieve their self-blame. And then 4 is to work through emotional blocks, which are fears and obstacles that might interfere with the parents doing 1, 2, and 3. And this is this idea that if a parent isn't doing it, and this was the really key piece for me to learn, that it isn't because they aren't motivated or they don't care, but because there's usually fear or self-blame or something like that that's stopping them from carrying out the task they were asked to do. What I didn't put on here is the attention EFFT puts to clinician blocks as well. And there's lots of work to kind of help make sure you carry out the tasks, which I actually think is really important for FBT, because FBT is a thing where people often don't carry out the entire model. There's a lot of, like, the family meal is something that a lot of people who do FBT will leave out because it's scary. And I think working through clinician blocks in EFFT can help FBT therapists have more fidelity to the model. Okay, EFFT format. In general, it can be a standalone approach or join forces with another treatment approach. You use the case conceptualization tool to set the structure of what you're working on. And there's a focus on family. There are options for family sessions, caregiver-only sessions, patient-only sessions, dyads. There's lots of groups, classes, workshops. You can send the videos on the Mental Health Foundation's website. Lots of teaching and practice of skills, and certainly chair work. I didn't spend a lot of time on that because I'm guessing if you're here, you know a lot of the EFFT format, but I wanted to make this, I made this Venn diagram. They're my favorite just to show how much overlap there is with these approaches. So both of them focus on empowering parents, not blaming, on the changing behavior, restoring weight. With eating disorders, there's a support for family dynamics. There's collaboration between the provider and the family and the person with the eating disorder. The piece that EFFT adds in that I think is the boon to everyone involved is addressing emotion processing. And that's why I love EFFT, and I'm guessing why a lot of you are here, is that importance of understanding that emotions are such a big part of what fuels an eating disorder. And I bring you this sort of classic EFFT slide of, how having a painful experience, and without any support leads to these maladaptive coping behaviors like restricting or binging or purging or exercising. But with targeted emotional support that the parent or caregiver learns in EFFT, the person develops confidence and skill with emotions and stressful situations, and therefore they have less of a need for the eating disorder. And so it's not only helping them with the family relationships, it's not only helping them get refed so that their brain is back online, but it's also preventing, in a way, relapse, because they have internalized a way to deal with their emotions without needing an eating disorder or something like that to process the feelings. So we'll talk a little bit about integrating them. And I have to say, if you're anything like me, I in the beginning wanted a blueprint for how to do this. And I'd show up to my supervision going, okay, what session do I do what and in what order? As FBT primary, as EFFT primary, how do I optimize this? And I wish that I had a nice evidence-based package for you, but I don't yet. But I think that in some ways it's really good because we don't need that. EFFT is super flexible and wonderful and can be used. You can jump in and use it in a moment when it's called for, or let the FBT stand alone. You can combine it. It's really lovely. So I'll just share some of the ways that I have used it. If you're already using an FBT protocol, maybe some of you here are, here are my favorite EFFT tools to help with emotion processing. So my most favorite is emotion coaching parents. Anyone who's ever come to a supervision session with me and will hear me talk about that all the time. And that's because for, the first year that I was in supervision with Natasha, every session I would come in and go, I'm doing this and I'm doing this. I tried this intervention and that intervention. And she'd say, are you emotion coaching the parents? It took a really long time for that to sink in for me. But I think you could fit emotion coaching parents in without doing anything else. And that helps the parents feel like you are holding hands with them. You're on their side. You become, they feel their defenses go down. They're much more willing and able to cope with all of the things you're asking them to do if they feel like you have validated their emotions and you're helping them figure out the next steps. So if there's one tool to incorporate, that would be the one to incorporate. You don't have to teach them anything. You need no extra sessions. It's just a stance to have with the parents when they're struggling. So if they say, oh, I did this week, you told me to give them this, sit with them at lunch and I just couldn't bear to do it. Instead of going in and educating on why do you need to sit with your kid at lunchtime, it's, oh my gosh, I really understand why it's so difficult to be there at lunch because you've got so much going on in your own day that it feels like there's not a single second to be there with your kid. And because every time you've shown up for lunch, your child has just, thrown the food at you and it's so exhausting and so horrible. And because maybe you don't want your kid to miss out on getting to have lunch with their friends, it feels like that's the only thing keeping them from getting super, super depressed. And you don't want that to happen. I really believe in you as parents and I'm here for you. And let's figure out how we can move in the direction of doing lunches. So that's kind of a way that you might use emotion coaching of parents in a session to help them feel like you're not blaming them or criticizing them for not following through with something. I found that to be really helpful, especially with eating disorders, if parents have diet culture stuff that they're still doing too. I think that has been something that's been really triggering for me as a clinician. And instead it's become a really lovely avenue to kind of be able to help parents through how hard that is to live in a diet culture, literally live in a diet culture, and then be asked to be feeding their kid all this food that really challenges some of those norms. Okay, so other tools that I like to integrate, certainly I think a lot of us where people start is teaching caregivers how to do emotion coaching for meal support and for body image distress. This is where I think most people step in. FBT therapists or therapists in general will step in and teach this to parents. It's an easy one to fit in. Using the caregiver traps is wonderful. I love using the animal models, the tree, super feeler handout I use with everyone. And then the chair work is really great. That's the one you need a lot of extra time to fit in. But my favorites to use in this are the caregiver chair work and the self-blame chair work. I have used a lot with many of my families and found it to be helpful because it is, as a parent myself, I think it's natural for a parent when their kid is suffering to go, what did I do? Why haven't I been able to figure this out? How could I have caused this? And so parents need a lot of support around transforming some of that. Okay, so different formats that you could use if you do want a format to integrate the two. So one would be an FBT focus. So this would be to use the existing FBT session protocol and then just add in teaching emotion coaching, behavior coaching, adding in block and chair work if as needed. So that might be a sort of easier family that doesn't, they already kind of have a lot of those skills and they just need to learn some of these pieces. So, an example I might give is a family I had where the parents are just really great. They were very naturally consistent and compassionate and close. And everything kind of went well through most of phase one. But then one of the places that was blocked was the kid really struggling with actually some self-harm and expressing anger. And so we added in a few parent-only sessions that focused specifically on teaching parents how to emotion coach kind of hidden anger that wasn't getting expressed. And that helped us, they used that. They went back and were emotion coaching hidden anger a few times a week. And then it was easy to move through the next phases of the FBT just by adding that one EFFT piece in. Another example would be an EFFT focus. So an example for that might be an older person or someone who had done FBT before and it did not go well, or they didn't want to do FBT for whatever reason. It's too much work. But so it wasn't going to work for the parents to be in charge of the food. So we weren't going to do that whole FBT approach, but that the parents would help with the emotional support at meals. And so we could do a lot of EFFT around kind of helping the parents do the emotional support and learn emotion coaching, do a therapeutic apology, help that go smoother so that they could really be good hand holders at mealtime, even though the kid was picking their own food and taking, a lot longer with the weight restoration process than there is in the FBT model. And then a true integration of the two is my favorite thing. If you have lots of time and resources and they can afford it and you can make this happen. I love to do this where I start with 3 sessions, even 3 2-hour sessions of EFFT with the parents and caregivers in FBT. So you're doing the whole FBT thing, plus adding in these 3 longer sessions of EFFT with the parents or caregivers before the first session or within the first week or 2 to add that in. Oh my gosh, that's really amazing. That's like the sundae with I'm an eating disorders therapist. I have to use food metaphors. It's the sundae with the chocolate and the cherry and the whipped cream and all of that. Sprinkles on top is when you have time to do all of that. And then you could keep that going throughout. You could even, if a family had the ability and the time and the resources, add in a second session a week in phase 1. So there's the session with the kid and the family, and then one just for the parent support where they can get lots of practice with emotion coaching and do chair work. You can encourage families to attend an EFFT workshop or watch the videos on the Mental Health Foundation's website. That's something that I do a lot when I know we're not going to be able to fit in more EFFT sessions. I ask my families to watch those videos. Also, something I've done here is a colleague and I have run a group for new FBT parents, and we've done a lot of EFFT stuff in the group. It's not like doing the whole workshop because we didn't have any workshops happening locally, but that really helped parents get some of those skills early on in the process. And that's something you could do. And then one easy thing is to start every family off with caregiver traps as part of the intake. So I have that in my intake packet, and it's something that we talk about in the first session. And then if there's time for nothing else, as I said, emotion coach the parents and caregivers every chance you get. It's this idea of cascading attunement. The more you attune to the parents, the more that the parents can attune to the kid. And then I'll just share how I think how these things help each other. I have found that when I add those pieces in, it really helps a lot with the self-blame, the blame of each other, of the kid. It helps. It's the best. EFFT is the best thing I've found for modifying that parental criticism piece. Something I found really hard in FBT is you're supposed to modify parent criticism, but it almost feels like you're then criticizing the parent for criticizing. So there's cascading criticism that happens there. But with EFFT, I can help the parent uncover with chair work what's underneath the criticism and that inner wisdom that they have from their love of their loved one for alternate ways and what the kid really needs, what they're trying to actually do by criticizing and what the real kid really needs that's underneath that. When I say kid, please, I also mean adults. I'm still a kid. We're all kids. You can be a kid till your 90s. Okay, I found that EFFT helps FBT parents be firmer sooner and able to jump in quicker with really following the kind of guidelines for refeeding. Even though there's the rule of 1 degree, it's almost like that permission, but that emotional work helps the parents just get through the blocks much faster. Parents feel so much more skillful at meal support when they have emotion coaching as a tool. On my own, I feel like it's really helped the alliance be stronger, and that the parents feel more connected. They feel more skillful. They like the therapy more, is my sense. The patient, the young person, feels more supported and closer to their family. And I have had times actually where I've done EFFT only with the parents, and then the kid has asked, the kid who refused therapy before said, can I see whoever the therapist is that you're seeing, because you're talking to me in this new way that feels so good and I want to know them. And then it suddenly becomes, full family therapy. So I've just found that the young people like this approach a lot, even if at first they're like, why are you talking to me in this weird way? They still, that's a way of trying to push it away and test it. But really underneath that, I think, can be so supportive to the kids. And then, the biggest piece for me is that I feel so much less burned out and I love my work. And the biggest surprise for me is how much I love now, going from someone who originally wanted to do the individual work and reluctantly did the family work. Now I almost, love just working with parents. I've got a lot of parents in my practice that I just see on their own. So those are my takeaways. And then I just wanted to share with you resources here. So at the top is the EFFT book. And then the books that I think are good if you're newer to FBT are the Treatment Manual for Anorexia Nervosa, a Family-Based Approach. That's the protocol and the manual, but it's hard. It's a harder one to read. I actually love this book by Lauren Mulheim, When Your Teen Has an Eating Disorder, Practical Strategies to Help Your Teen Recover from Anorexia, Bulimia, and Binge Eating. And then this is my favorite for food, is that book I talked about earlier, The Plate by Plate Approach, How to Nourish Your Child Through an Eating Disorder by Wendy Sterling and Casey Crosby, who are some of my colleagues here in the Bay, and they're really stellar in the book. So many of my families love it. I've actually given it to adult clients with eating disorders to learn how to feed themselves as though they were their own parents. So it's a great book. There's the EFFT videos on the Mental Health Foundation's website. And then Feast is an organization that has great tools for families. It's Families Empowered and Supporting Treatment of Eating Disorders. So that is everything I had to start with, but we've got some time for questions. So now I've got the chat box and I can see it. Somebody asked, so please put your questions in the chat. Somebody asked about if the animal models and super feeler handouts could be shared. I do not have the technical ability to put them in here, but my email's on the bottom there. I can email you, but they're all on the Mental Health Foundation's website. If you go into the clinician section, you can find all the handouts there. Any other questions? What do you typically focus on when you see the individual for 10 to 15 minutes? Great question. You do actually, in the protocol, you weigh the kid, and you ask about what symptoms are going on that week, what's working and what's not working. And then I always ask if there's things that they really want to focus on in the session with their parents, things that they want to bring up and talk about. And, you also do a lot of kind of rapport building during that time. So often it's like hearing about their dating life, or, what events they have going on, or things they're passionate about at school and they care about. It's where you build the relationship. They can complain about their parents a little bit so that, they feel a little bit like you're seeing the whole picture of what's going on. It's a fun part of the session sometimes. Okay. Any good resources for doing FBT with kids struggling with binge eating? It's a great question. I think there was a book that was written on it, but I actually couldn't find it to put in the things. I think that Lauren Mulheim book has some good resources on it, but really the thing that I like to really want to emphasize in this is that binge eating is, I believe, starts with restriction, right? If you know that CBT formulation of an eating disorder, that binge eating is usually following some restriction. And so I really like to focus on helping that regular eating, of having those meals, incorporating those binge foods, and then having support after sessions to be able to prevent binging. So, and you can also find out what time of day the person usually binges at, and make sure that there's caregiver support at those times. So if they tend to binge right when they get home from school, can for a period of time, can we get the caregivers or somebody supportive to be there in order to support them during that time? Let's see, and teaching those self-soothing skills and all of that can be helpful. Copy of slides, great question. I will ask Natasha about if there's a way to get everyone a copy of the slides. Okay, quick answer on the perspective of the role of the dietitian. I love dietitians. I work with them all the time. They're some of my favorite humans, and I love incorporating them into this. I wanted to present the model faithfully, which doesn't tend to use dietitians, but I think most people in practice do use dietitians. And I actually know a lot of dietitians that are very good at facilitating FBT, actually. But what I like to do when I work with a dietitian is have the dietitian work with the parents versus work with the kid, so that it's really preserving that idea that the kid is learning that the parents are bigger and stronger than the eating disorder, and that the parents know how to help them, versus getting in a situation where the parent is saying to the kid, well, you have to eat this because your dietitian said to. But instead, the parent is empowered by what they learned from the dietitian to say, hey, I want you to eat this because I know this is what you need, and I'm here and I have your back. But the dietitians can be so helpful to help the parents work through their own fat phobia, diet culture, fear and anxiety, their own food issues, and then even get an understanding in our world where it's so confusing what food could look like, to get help and support, being creative along the way with what those meals should be. Okay, so I know we're at time. I'm still going to answer the messages that are here, the questions that are here, but just don't add any more because I won't be able to get to any more. Okay, siblings joining after 10 to 15 minutes. Yes, siblings are often involved in FBT. I don't have time to talk about all of it, but sibling rivalry can absolutely be something that's addressed especially in that phase 2, phase 3. Phase. Oh, and then you're saying I'm so happy that you all are liking this. You're welcome. I'm so grateful that you came to talk about something that I love so much. Okay, kid really doesn't want to participate in sessions. How hard do you personally try to get them engaged in the sessions, or do you just focus on working with the parents for a while before trying again? I will let the kids sit there silently. I will really try to get them engaged by being warm and friendly, telling them how much I care about their point of view and that they're always welcome. But I really don't want them to feel forced at all, to participate. And I'm very happy to meet with just the parents in them. And I think that really takes the burdens off the kid as well. And your messages are all so sweet. Oh, Rachel, you've got your hand up. Yes.
Well, first of all, I don't want to take any more time because it's one after 11, but I just wanted to say this was so wonderful, and that clearly you need to do a longer presentation because there's so much here to ask about and to talk about. So I'll save my question for another time.
Okay, thank you so much. Yeah, I know, and I'm a big talker too, and obviously I'm just so passionate about these topics and so grateful to the people who developed these treatments and all the people in the EFFT world for all the mentoring and support in learning this. So it's been so lovely to be with all of you. You have my contact info if you have more questions that come up afterwards, and thank you so much for being here. Have a wonderful day.